Okay, I'd like to extend you all a very warm welcome to this evening's lecture, and it gives me great pleasure to introduce Dr. Lynne Dawkins. Just before I do, there might be some latecomers, so if there are, could I just ask those of you who've sort of sat near the middle, you might need to move along to save you having to get up, so be prepared to move along and leave some spaces near the centre. And also, just before I introduce Lynne, I want to make a shameless plug for an initiative from my own institute. I'm Anne McNeill, I should have said that at the start. I'm a professor of tobacco addiction at King's College London. But the shameless plug is for women, because from the 12th of November, based on average pay for men and women and the pay gap across the UK, women have been working for free. So that was Monday, and we don't get paid again until the 1st of January. So not only is Lynne giving up her days for free, she's also giving up her evening tonight to give this lecture. So well done, Lynne. I first became aware of Lynne in about 2002, I think it was, when you were at Goldsmiths College, and she'd just done her PhD, and she was publishing some really interesting work on nicotine, response inhibition, reward. And then I think you moved to the University of East London in about 2006. And then in around 2012, started to publish research on electronic cigarettes. And I think you just pipped us and our group because we published our first paper in around 2013. And actually, I want to applaud you for the public lecture that you gave, Lynne, in 2013, because there wasn't very much known about electronic cigarettes at that time, and I thought you were very bold to go and give a public and open lecture on electronic cigarettes at that time. And then you moved here to in 2016 to London South Bank University, and you've continued to publish some excellent and innovative cutting-edge research on electronic cigarettes. So I'm really looking forward to your second public lecture tonight. Thanks very much.
Thank you very much, Anne. I wasn't expecting you to say all those nice things. Thank you so much. And it's a real pleasure to have you here tonight hosting this event and acting as chair for us. So thank you so much for agreeing to come. Really appreciate it. Okay, so as Anne said, I did deliver a public lecture in 2013, and at that time, very little was known about e-cigarettes. Since then, there have been a lot more publications. E-cigarettes have evolved and improved. There's been hundreds of research articles published now on the topic, but public perceptions are still confused. There's incredible naivety and ignorance about e-cigarettes. So I thought it was about time that I stood up again 5 years later and gave an evidence update on what we know now. So that was how this kind of came about. Before I continue, these are my disclosures. So I have acted as a consultant for the pharmaceutical industry, as an expert witness in a litigation case, and prior to that, I've conducted some research for e-cigarettes companies, which my university at the time received funds, and I have no conflicts of interest with the tobacco industry. So, what I'm going to talk about today, so my office mate and colleague Sharon Cox at the front here are often talking about things that we hear people say about e-cigarettes. These are people we interact with every day, students, colleagues, taxi drivers, hairdressers, university health and safety officers, and so on and so forth. And we sat down and made a list of common myths or concerns or misperceptions that we'd heard about e-cigarettes. So that's how I'm structuring this lecture, around some of these myths that we've heard, and then I'm going to present the evidence surrounding that particular topic area. So this will kind of take us through regulation, who's using them and why, nicotine and addiction, fires and explosions, health issues and potential harms of e-cigarettes, e-cigarettes and quitting smoking, and then the so-called gateway effect. Are they leading young people to become new smokers? And then I'll try and sum it up at the end. Okay, so before I move on, I think we just have to have a bit of a recap on what e-cigarettes are. Most of you, I'm sure all of you have heard of e-cigarettes now, but there are still a few concerns and confusions around this. And these products have evolved massively since I gave my last lecture in 2013. From the earliest devices, these cig-alikes that were around then, and these kind of pen-like devices were around too. But we've seen these devices evolve and improve. Battery safety has improved. Atomizer technology has improved massively. And devices have changed. So we have some all-in-one devices now, through to the massive kind of so-called box mod type devices. And then much more recently, in the last year or so, we've seen e-cigarettes get a bit smaller again. Not everyone wants large conspicuous devices, so these really fit this bill. These kind of sleek, sophisticated, they look like, what do you call them, memory sticks more, these dual devices. And alongside this change in the devices, we've also seen change in terminology. So we're not just hearing the term e-cigarettes anymore. In research, researchers like to refer to the electronic nicotine delivery devices, or ENDs, which is quite an accurate description of what these devices are, but it doesn't really roll off the tongue, and we don't commonly hear e-cigarette users referring to their electronic nicotine delivery device. We're seeing an increasing move to terminology around vapes, vape pens, and vaporizers, which I quite like, because one thing e-cigarettes are not is cigarettes. They don't contain tobacco and there's no burning. So I quite like the term vaporizers, but that can also cause confusion. Only the other day, I was talking to a student who said to me, well, is it an e-cigarette or is it a vape? E-cigarettes contain nicotine, vapes don't. So there's still a lot of confusion, even around the different devices and what they are and what they aren't. So for clarity, I will be using the term e-cigarette because that's what I'm familiar with and what I've tended to be using all this time. And when I refer to somebody who uses an e-cigarette, I may refer to an e-cigarette user or to a vapor. Okay? So the first thing that we commonly hear is we don't know anything about them. There's been no research on them, or there's been hardly any research on them. Well, I think we can safely say wrong to that one. We do know quite a lot about them, as you will see by the end of this lecture. And there have been quite a lot of research studies published on e-cigarettes. So I just did a simple search with one database using the term e-cigarette in the title or abstract of articles. And this is what I found. So back in 2008, there were no published studies, only 3 in 2009, and there was a steady kind of trickle of publications coming through, up until 2014, when we saw a huge surge in publications. So everybody had jumped on the e-cig research bandwagon by that time. And even this year alone, there's been over 500 research articles published on electronic cigarettes. And I may have found even more if I'd used the word vape or vaporizer or ENDs and so on. So we do know quite a lot about e-cigarettes. There have been quite a lot of studies published. But one caveat there, just because there's been quite a lot of studies published on the topic doesn't mean every single study is conducted with the utmost rigour or accurately designed or interpreted as carefully as the results could be. So that's something to bear in mind that I will return to. Next thing we hear quite often, even recently, is they're not regulated. Well, e-cigarettes have always been regulated in one way or another. Prior to 2016, they fell under the General Product Safety Regulations. And since 2016, under the EU Tobacco Products Directive, which also covered electronic cigarettes. And in the UK, we are in quite a unique position because there are 2 routes to market for electronic cigarettes, the consumer route and the medicinal route. So the consumer route requires a notification process. So manufacturers have to notify that they intend to market a product, and that involves providing information about the device itself, about the liquid, the content of the liquid, the emissions, the packaging, safety reporting, and so on. There are minimum standards for safety and quality. There are standards for the nicotine concentration in the e-liquid, and there are standards on there are limits on the size of the tanks, the reservoir that holds the e-liquid, and on the size of the refill bottles as well. There are advertising restrictions, so no cross-border advertising is permitted. Manufacturers can't make health claims, although the Advertising Standards Authority, just in the last couple of days, have made an announcement about this and maybe changing this. And finally, there is a reporting system for healthcare professionals and users to report any adverse or side effects to the Medicines Healthcare Products Regulatory Agency. So a lot of regulations in place, and the medicinal route requires a slightly different process, different standards for safety and quality, a much more burdensome process, but higher nicotine levels are permitted via that route, and advertising and health claims to an extent are allowed. But we haven't seen any products completely go through that process as yet. So we don't have any e-cigarettes in the UK licensed as medicines. Okay, so e-cigarettes are regulated, but that's not to say that policymakers always get it right straight away. And there are some issues or unintended consequences associated with the EU Tobacco Products Directive. So first of all, it was developed at a time before there'd been much research at all on e-cigarettes. So prior to 2013, and if you remember from the graph I showed earlier, there wasn't really that much research published. So it was a bit of a guess, really, and e-cigarettes were kind of shoehorned into the existing Tobacco Products Directive. So it's not surprising that there are some issues or some unintended consequences associated with these regulations. So let's just briefly go through those. No advertising, no cross-border advertising, that is. Point-of-sale advertising is allowed. But restrictions on advertising just means that manufacturers can't get their message about their reduced-risk product to smokers. And less presence just means less reach, in turn, more people smoking. The addiction warning label that is now mandatory on e-cigarette packs looks something like this. There's also an extended version. It has to take up 30% of the pack. It looks just like a harm message that you see on cigarette packs. It's quite an intimidating message, and some of our research has shown this actually puts smokers off intending to purchase and to use an e-cigarette. So that may not be the most helpful message either. There's a cap on the nicotine content. This can be a problem for so-called hardcore smokers, heavier smokers, who may need higher concentrations of nicotine in their e-liquid. And also capping nicotine sends this message that nicotine is the harmful component of e-cigarettes. That encourages people to use lower nicotine concentrations, and then they end up vaping more. I think my biggest problem with this one is it's just not based on any evidence. And in fact, we've shown that there may be some other harms associated with that, which I'll revisit later. There's limits on the tanks and the bottle sizes. So if you can only fit 2 millilitres of liquid in your tank, you have to carry around more bottles with you, you have to fill it up more often, more faff, more hassle, you might as well smoke. And then one example from the US. So I've concentrated mainly on the UK in this session, but an example from the US is very burdensome process for actually making any changes or modifications to existing devices. This not only stifles innovation, but if somebody wants to improve on a device to make it safer, they can't do that very easily either. So this is another way that unnecessary harm may be a consequence. So that's regulation. Moving on to the next myth or concern. We hear this a lot. Young people are using them. Non-smokers are using them. Everyone's using them. So, well, let's have a look at who is using them. And for this, I am drawing on data from the charity Action on Smoking and Health, who have been conducting a lot of surveys on smoking and e-cigarette use over the years. And yes, quite a lot of people are using e-cigarettes. So according to ASH, an estimated 3.2 million adults in Great Britain are using them. And this has increased from 700,000 in 2012. But if we look a bit more closely at who's using them, you can see from the graph here, which captures data from 2014 through to 2018, that most people using them are smokers, shown in the black line here, but even more ex-smokers, 51.6%. By contrast, the people who describe themselves as never smokers, in orange, represent 4.2% of total e-cigarette users, and that translates to about 0.5% of the general population. So most people who smoke are ex-smokers or current smokers. And if we just look at some data from another survey, this is taken from the Smoking Toolkit survey. It's a monthly survey of households in England. And again, we can see a very similar picture from this survey. So if you look at the blue line, this is people who have never smoked and who have reported using an e-cigarette. It's actually very similar to people who have never smoked who are using NRT, nicotine replacement therapy, such as patches, gums, lozenges, and so on. By contrast, most people who are using e-cigarettes are long-term ex-smokers. And similarly, the use of NRT is mostly concentrated in ex-smokers rather than in non-smokers. But there is some use amongst never smokers. And this is always going to be the case for any consumable product. It may get into the hands of some people for whom it wasn't intended, but in the most part, it is reaching those for whom it is intended. Okay, so e-cigarette use, never smokers, low, similar to rates of NRT use. Okay, so we've looked at who's using them. So let's look at why people are using them next. So again, this is taken from the ASH survey, and it asked people who were using an e-cigarette what their main reason was for using. And they divided e-cigarette users up into, it's easier to see here, into current users who are also currently smoking, shown in orange, and current e-cigarette users who are ex-smokers, shown in white. And you can see clearly that the main reason that the majority of people gave was they were using e-cigarettes to either quit or abstain from tobacco smoking. So mostly these products are ending up in the hands of smokers or ex-smokers, and they're mostly being used for quitting smoking, which is what we're intending. Okay, so moving on to the next myth, or the next concern. They contain nicotine, so it's just swapping one addiction for another, or it's just transferring the nicotine addiction. So, is addiction really evil? As some of you might remember this public health campaign back in the 1980s where Superman defeats this evil nicotine guy. Is nicotine really evil as it is portrayed to be and as many people think it is? Well, let's have a look. What's wrong with nicotine? Professor Mike Russell from King's College London said years ago, back in the 1970s, people smoke for the nicotine, but they die from the tar. And by that, he meant that nicotine is the main component of tobacco smoke. It is the addictive ingredients, but it's the burning associated with smoking that causes all the harms. So burning is associated with tar and carbon monoxide. So tar is a collective term used to describe all the other compounds in cigarette smoke. And the problem with tar is it's sticky, so it sticks to the lungs, it sticks to the airways, and this means that the tiny hairs that usually sweep the carcinogens out of the body can't do their usual job, and this allows the cancer-causing agents to build up over time. So the main problem with tar is over time it can result in cancers, lung cancers, but other cancers too, and respiratory disease. Carbon monoxide, again, found when you burn tobacco smoke, an extremely toxic gas. And carbon monoxide attaches itself to the red blood cells. And the red blood cells usually transport oxygen around the body. So because carbon monoxide comes along and attaches itself to those red blood cells, knocks off oxygen, it means that over time oxygen can't travel around the body effectively, and over time this can produce cardiovascular disease. So if we can give people the nicotine that they crave and that they desire in the absence of burning tobacco, then this should eliminate almost all the harms and should be a win-win situation. And this is the basis of what is commonly referred to as tobacco harm reduction, and was what Mike Russell was proposing all those years ago. And this is the basis for nicotine replacement products, patches and gum and so on. Give people the nicotine they need without the harmful effects of burning. Okay, so continuing with concerns about nicotine, if we ask members of the general public what they think about nicotine, then generally people don't have a very accurate picture here. So these data were published very recently, taken from some researchers working with Anne's group at King's, and it was a survey of over 2,000 young people in Great Britain, and they were simply asked how much of the harm from smoking comes from nicotine. Only 8% gave the correct answer, none or a very small amount. And almost 60% said it was somewhere between half the risks to almost all of the risks. You might think, well, you know, these were young people. Adults perhaps would have much more awareness, but no. And your group has done a similar survey with adults and found a very, very similar picture, with about 50% of people thinking that it's the nicotine that's harmful, that it's the nicotine that's causing cancer. And this just isn't correct. Okay, so we're still talking about this theme of transferring a nicotine addiction. You're smoking, you're addicted to nicotine, you're transferring to vaping, you're still addicted to nicotine. Well, Is nicotine addiction actually a problem if it's isolated from the harmful effects of burning? Well, we have some evidence from the lung health study that long-term use of nicotine replacement therapy products is relatively safe, and it's not been shown to cause cancer. But we have to ask ourselves, when we're thinking about is nicotine addiction a problem for whom? Is it a problem for public health if people are using nicotine through vaping? Well, probably not, because we know vaping is considerably less harmful than smoking. So the residual health risks are quite small. It may be an issue or a problem for the individual. It may be that cost is an issue, or the person is concerned about other people's perceptions of their vaping, or they don't want to feel that enslavement to nicotine or to use of a product, and that's fine. It may be a problem for the individual, but those are not major health concerns. But we want people to be at a level that they feel comfortable with, of course. Coming back to this issue of nicotine addiction, there hasn't been that much research on how addictive taking nicotine in the form of vaping is. But the articles that have been published on this topic have generally shown that vaping is much less addictive than smoking. So you can take some comfort in that. Okay, this is similar, this kind of myth. My wife or my boss, my friend, agony aunt, dog, or whoever it is using it constantly. That can't be good. They must be getting more nicotine. And this is, again, something we hear a lot, phrased in various different ways. Before I take you through this slide, I just want to point out that nobody has actually died from getting too much nicotine from smoking or vaping. It's a self-limiting mechanism. You smoke or you vape too much, you feel sick, so you stop using. And humans have the ability to vomit. So that actually gets rid of the nicotine. Rats and mice can't, but we can. So more to the point, vaping too much or vaping constantly is a consequence of the way nicotine is actually delivered through smoking versus vaping. So vapers do tend to report that they graze, that they will use it more continuously throughout the day, whereas smokers will use more intermittently. They'll have a cigarette, they'll go back to work for an hour and have another cigarette maybe an hour or so later. And it's not surprising that we see these differences in patterns of use, that vapers use more constantly throughout the day. When we look at the pharmacokinetics, the way nicotine is delivered. So if you look at the orange line here, this is nicotine delivery from cigarette smoking. You can see on the vertical axis the nicotine in the blood. Very rapid increase to a very high level within minutes. Vaping, by contrast, shown in the red lines and the blue lines, these are taken from two different sorts of e-cigarettes, in general show much slower nicotine delivery. This depends on who's using it, it depends on the device, but generally speaking, we see a much slower build-up of nicotine in the blood. So you can get to fairly high levels, but it takes a lot of vaping, over 30 to 40 minutes. So it's not surprising that people are using their e-cigarettes more continually than they were when they smoke, because people are trying to maintain a constant blood nicotine level, a level that is optimal for them. And people can change the way they vape or smoke as well to maintain this level. So we've shown in some of our research that when vapers switch to using a lower nicotine concentration in their liquid, they increase the amount that they puff, and they maintain that steady kind of nicotine level in the blood. So this might sound counterintuitive, but if you are concerned that you're vaping too much or somebody close to you is vaping too much, try upping the nicotine. Try using a higher level of nicotine if that is a concern for you. Okay. Moving on to the next topic then, fires and explosions. So e-cigarettes, they're always exploding, they catch fire. Okay, so I've taken some data from the Public Health England report for the next two slides. But the first thing to say is, like other portable electronic devices, e-cigarettes contain lithium-ion batteries. So these are also found in mobile phones, in laptops, portable cameras, and so on. And there are many advantages of lithium-ion batteries, but there are some disadvantages, because on occasion they can overheat, and rarely, thankfully, they can explode. So in the Public Health England report, they requested information from 41 fire and rescue services across the UK, and they asked for data on call-outs related to e-cigarettes and fires between 2015 through to August 2017. So the 2017 is just through to August. And you can see the number of fires that were reported. The total numbers are shown in blue, and there was an increase from 2015 to 2016. So these are specifically e-cigarette related fire call-outs. But most of these call-outs were actually due to false alarms. So there was an increase in false alarms from 2015 to 2016, shown in grey there. The actual number of fires is shown in orange. There were 24 casualties reported in total across all these call-outs. Thankfully, no fatalities. And the number of actual fires is very similar to the numbers reported from mobile phone battery explosions and fires as well, just to point that out. The Public Health England report also searched the literature for case studies and publications related to e-cigarette burns, and they found 24 such studies, 6 that were occurred in the UK, the remainder outside of the UK. And these explosions usually occurred when people were carrying the device around in their pocket, sometimes whilst the device was being charged, and occasionally whilst it was being used. Now, of course, if explosions occur whilst they're being used, that isn't a trivial matter, because you can have facial burns and so on and so forth. But although these types of explosions are commonly reported in the press, thankfully they are very rare. And if we compare the numbers of explosions and fires from e-cigarettes to from tobacco smoking, this really puts it into perspective. So these are data recorded from the London Fire Brigade. So these are fires in London over the last 3 years. And you can see that tobacco-related fires really do dwarf the numbers of e-cigarette-related fires. And although there were many injuries and some fatalities from tobacco-related fires, thankfully, there were none associated with e-cigarette use. And this led the London Fire Brigade to conclude that although 4 times as many people smoke as they do vape, there were almost 300 times more smoking-related fires in London than those caused by e-cigarettes. That was in the last 5 years, meaning vaping is a safer option in terms of fire risk. Okay. Now, this is probably a bit of a combination of all the other concerns about e-cigarettes put together. And very commonly expressed, they're just as harmful as smoking. And we sometimes see this qualified by further statements such as, well, we just don't know the long-term effects. We didn't know the long-term effects of smoking. That took years to uncover. And in fact, we used to think that smoking was good for us. Okay, so harm perceptions first. So data taken from the ASH charity again. So ASH have been collecting data on the number of people's perceptions on how harmful e-cigarettes are compared to smoking. And this presents the data from the last 5 years, from 2013 through to 2018. Correct answer is a lot less harmful. In 2018, about 20% of people reporting accurately that e-cigarettes are less harmful. Worryingly, and we saw this increasing trend here, but it's levelled off in the last 2 years, but still 25%, a quarter of people, still think that e-cigarettes are more or equally harmful to tobacco smoking. Now, tobacco smoking is so very bad. It's hard to understand if people can think that. Well, for me anyway. Another quarter just don't know. So a quarter think they're as harmful as smoking, another quarter don't know. This is a real concern. But it's not surprising people think this way when they're seeing headlines such as this: vaping as bad as fags, vaping may raise cancer and heart disease, study suggests. E-cigarettes are no safer than smoking tobacco. Vaping could be worse for your health than actual cigarette smoking, research claims. And this can be a real problem because even if there are qualifications later on in the article, many people don't read the articles, they just see the headline, and often there are no qualifications anyway. So it is an issue because if people believe that vaping is as bad as smoking, there is no incentive to switch or to continue. But on the other hand, we also sometimes see the extreme opposite. E-cigarette vapor has no toxic effects. It's as safe as air. Shock study claims. I mean, that's in the Daily Mirror, who also think vaping could be worse for your health than cigarettes. So there's a lot of confusion here. It's really not surprising that people are very confused about how harmful e-cigarettes may be. So before we look at some research studies on harms, I just have a few things that I think really need highlighting. So first of all, as I said earlier, it's the burning of tobacco that is responsible for almost all the harms of smoking. So tobacco smoke contains over 7,000 different compounds. We know that 70 of those cause cancer, and tobacco is burnt at around 800 degrees C. Vaping, by contrast, contains far fewer components: nicotine, propylene glycol and vegetable glycerin, which are the vehicle for the nicotine delivery, and flavourings. And they're heated. They're not burned. They're heated to a much lower temperature. So just based on this simple fact, there's no burning, we should already have a very good idea that they are not going to be as harmful as tobacco smoking. Some other things we need to consider So we hear people say, we're not going to know the harmful effects for 20 or 30 years. We need to wait for people to have been vaping for that long before we can really, truly estimate the harms. Well, that's true to an extent, but we do have a number of techniques available at our disposal at the moment that can help us estimate the harms. We can generate vapour and capture it and look at the content of that vapour. We can expose cells to vapour and see what the effects are. We could use animal studies, but I've got something to say about that. And so on and so forth. So there are things that we can do now. On the topic of animal studies, we have to be very careful here. Sometimes the types of headlines that we see in the newspapers are based on rat and mice studies. And exposure conditions are often don't accurately reflect how vapers would use an e-cigarette, yet alone for the biological differences between humans and animals. We have to be very careful extrapolating those findings. And on the topic of realistic exposure conditions, this is a really important point. So when we're designing studies, whether it is with animals or cells or with humans or so on, we need to make sure that when we're exposing cells or animals to vapour, that actually reflects the way vapors use a device. So vapors don't bathe in e-liquid, and they don't inhale 100% of every single puff they take over 24 hours. And they certainly don't continue to use if they get a really bad burning taste. So, however, some of the studies have used those types of conditions and then made conclusions that e-cigarettes are just as harmful as smoking, cause cancer, and so on and so forth. So we have to be very careful when we're designing studies and bear these kind of things in mind. Human studies, of course, the best because it's humans that we're talking about, but we also need to remember that even if we do show that there is some evidence of exposure to risk or some possible indicator of development of a disease, that almost all vapers are either current smokers or ex-smokers. So any kind of indicator of harm or health effect may be due to their prior smoking behaviour. Ideally, of course, we want to take a group of non-smokers, have them vape for a period of time, and then see what effects there are. But ethically, we can't do that, and nor would we want to be encouraging non-smokers to use. But it's just trying to make the example that it's very hard to draw conclusions when people have had a history of smoking. And the other thing is the biomarker meaningful. So the thing that we're measuring, does that actually tell us anything about risk or disease development? So some studies, for example, have shown that after a short-term use, the arteries become harder, or people exhale a bit more nitric oxide, and then they have taken that as evidence for this shows that there is some harm. We don't actually know whether those things, whether arterial stiffness, exhaled nitric oxide, has any relationship with the later development of disease. So when we are conducting these studies, or when we're scrutinising other studies that have been conducted in this area, we need to make sure that the exposure conditions are realistic and that any measured effects are actually a marker for a specific disease. I've just remembered that quote from Peter Hayek, who some of you may know, and he said something along the lines of, if you burn a piece of toast to a crisp, you can almost certainly find a whole load of cancer-causing agents in that, but nobody's going to eat the toast in those conditions, so therefore it's not harmful. And it's the same with e-cigarette and vapour. It's not really very useful to show that exposure to vapour under unrealistic usage conditions causes harm if nobody uses it in that way. So just some things to bear in mind. So now I've ranted on about that, let's look at some, we'll look at this first, then we'll look at some data. Just wanted to clarify that perhaps one of the best ways of trying to estimate harms now, rather than waiting 20 or 30 years, is to look at biomarkers. So this basically means something that can be measured in saliva or urine or expired breath, and which can be used as an indicator of a particular disease state. These can be tested right now. We don't have to wait. Ideally, they should be short-term. They should have a short half-life, so they're out of the body after a matter of days or weeks or months. So then we can be quite certain that they're not there as a result of previous smoking. And they need to be reasonably specific, easy to measure, and clearly linked to a specific disease. And one very good example is NNAL. So NNAL is a breakdown product of a particular type of nitrosamine known as NNK. And NNK is a known potent human lung carcinogen. So NNAL is a clear biomarker for lung cancer, and it's very easy to measure in urine. So here we can get quite a good idea of cancer risk based on something that we can measure right now. So there have been 8 studies that have been published on this area with a total of 658 participants. The types of studies that are presented use a whole load of different methodologies, which is a strength for making these kind of conclusions, and they're presented along the horizontal axis in terms of how long the participants had been abstinent from smoking. So short length of time of abstinence from smoking over this end through to longer abstinence from smoking at the far end. And given that NNAL takes a few weeks or months to get out of the system, then obviously these types of longer term abstinence are better for inferring health risks. The red line across the top represents the level that we see in smokers. So we're using that as our comparison. So across all these studies, you can see that there are slight variations, but if we take the overall average, there's a 91.4% reduction in NNAL compared to levels found in smokers. And if we just focus on these studies on the right-hand side that used participants who had not smoked for 4 weeks or more, this goes up even further to around 96%. So that's encouraging. But we wouldn't just rely on NNAL. There are other biomarkers that we can measure. So these are some of the other different biomarkers we can measure for cancer, respiratory disease. We can look at expired carbon monoxide, which is a very good indicator for development of cardiovascular disease. And there have been a number of studies published looking at these biomarkers as well. So here are the results from these studies. So you can see overall a reduction somewhere between 40 and 90% compared to the levels of these biomarkers that are found in smokers. But what we also need to look at is how these compare to non-smokers. So these dashed lines now represent levels seen in non-smokers. And as you can see, they're very similar because these kind of exposures can be found in dietary sources, in our environment, and so on. So these types of studies, and of course there are many more, but have led both Public Health England and the Royal College of Physicians to conclude that e-cigarettes are far less harmful than tobacco smoking. And when we say far less harmful, the Royal College of Physicians have stated it's not possible to precisely quantify the long-term risks, but the risks are unlikely to exceed 5% of those associated with tobacco smoking. Or put another way, in the Public Health England report, e-cigarettes are 95% safer than tobacco smoking. And this is also echoed by Cancer Research UK, the largest cancer charity in the UK, also the largest funder of e-cigarette research. And they have produced a range of very useful infographics. And you see many of these actually in vape shops, which very clearly convey the key messages about nicotine, cancer risk, and so on and so forth. Okay, so moving on, they don't help smokers to stop smoking. We're talking about e-cigarettes, in case you'd forgotten. Okay, so first of all, they're definitely very popular for use in a quit attempt. So the green line here shows that around 2011 to 2012, they really increased in popularity. This graph shows the main methods people are reporting that they're using in their quit attempts. So whilst nicotine replacement therapy over the counter decreased in popularity, e-cigarettes have become much more popular. We'll wait to see next year whether this dip goes back up again. So they're definitely the most popular method for quitting, but how successful are they? And the literature on this is really mixed. So there have been 7 reviews since 2015 with meta-analyses. So a review captures existing publications and pulls them all together, and a meta-analysis is a statistical technique that allows you to increase the overall sample size by drawing together samples from various different independent publications. So you have statistically more power and you can estimate an effect size. So we've seen 1, 2, 3, 4, 5, 6, 7, as it says there, 7 such reviews and meta-analyses, but with 3 different overall findings. So firstly, the top 2 reported that nicotine e-cigarettes increased quitting. The next 4 reported there was no effect on quitting. And then the last one actually reported that use of an e-cigarette actually decreased your chances of quitting. So why are we seeing these huge inconsistencies? So these relate to the types of studies included, first of all. So the top 2 only included randomised controlled trials. So these are trials specifically designed to test whether e-cigarettes compared to some control can help people quit smoking. So individuals who smoke are randomly allocated to a nicotine e-cigarette, or in these cases a placebo e-cigarette, followed up to 6 months to a year, and their quitting is recorded and verified biochemically. So the top 2 just included those types of studies. The next, well, all the others actually included a much broader range of studies, not only randomised controlled trials, but surveys, cross-sectional surveys which just record information at one point in time, or surveys where people are followed up over a period of time, and they included studies that weren't specifically designed to actually test whether e-cigarettes help people quitting. So, for example, some of these participants that were included may not have been using e-cigarettes to quit. They may have been using e-cigarettes just because they fancied trying it, or to get around smoking restrictions, or so on and so forth. Many of the studies also selected people who had been successful at quitting with an e-cigarette out of the study at the beginning. So if those people who've already been successful at quitting are not included, but you are including people who are currently using an e-cigarette and still smoking, it's likely that those people are the ones that are finding it harder to quit. So you're biasing the sample from the outset. And these reviews included studies such as that. The types of outcomes that measured also differ. So the time of follow-up, how smoking cessation is actually defined and qualified and verified, and so on. So that can partly explain why we're seeing some of these huge differences across these reviews. The studies that were specifically designed for quitting, rather the reviews that included studies that were specifically designed for quitting, did generally find a positive effect of using nicotine e-cigarettes for quitting smoking. However, the effect size wasn't huge, and there have only been 2 published randomised controlled trials that were included in these reviews because they're costly, they take a long time to develop, so it's easier just to do a quick survey. And these randomised controlled trials were conducted very early on in e-cigarette history and used some of the earliest devices that weren't the most effective products, let's be fair. So we are still waiting for the results from existing trials to be completed, trials that have used some of the newer products, to see if there's any changes there. We can also look at data in another way. So this is information captured from stop smoking services in England, and the English stop smoking services all record 4-week quit rates, and they offer a range of medications, nicotine replacement therapy, but also bupropion, marketed as Zyban, and varenicline, known as Champix, and combinations of these as well. So across these stop smoking services, the average quit rate at 4 weeks is 51%. And you can see the ones shaded in red were ones where an e-cigarette was used. So an e-cigarette used on its own, 59%, which is actually quite similar to varenicline, which is Champix. Interestingly, combining an e-cigarette consecutively with a licensed medication seemed to be even better. But we're not seeing amazing results here. We're seeing that they are at least as good as standard licensed stop smoking medications, perhaps a little bit better. However, because e-cigarettes are much more popular than these traditional methods for stopping smoking, even if they're just a little bit better, this can mean that at the population level, this can result in quite a large number of additional successful quits. And this is what Robert West and his colleagues have attempted to do at UCL. So they've taken data using the Smoking Toolkit survey. They capture data about smoking and methods used for quitting. And they have modelled this to estimate how many additional long-term quits were associated with the use of e-cigarettes. So using this method in 2014, it was estimated there were an additional 16 to 22,000 quits that would not have otherwise occurred. Using a slightly different method, based on data from 2015, the same team estimated an additional 18,000 quits due to e-cigarettes. And then in the Public Health England report published earlier this year, based on data from 2016, using the same methods as West, estimated 22 to 29,000 additional quits. And if you vary some of the assumptions about the types of products people were using or might be using anyway, this was even higher. Where's my pointer? So based on this and the reviews and the randomised controlled trials and on the stop smoking service data, I think we can conclude that e-cigarettes appear to be a successful method of quitting for many smokers. And at the population level, this can result in a considerable number of extra long-term quitters. And alongside that, it's also reassuring to see that smoking prevalence continues to decline, albeit slowly, but there's a steady decline, and this certainly hasn't reversed at the time when e-cigarettes have been around. So if e-cigarettes were somehow deterring people from smoking, or making it harder for people to quit, we wouldn't see this continued smoking prevalence, perhaps. So that's encouraging. So this is the final myth or concern that I'm going to address. They may lead young people to start smoking. So I've already presented some data on use amongst non-smokers, and that seems to be fairly low, but we haven't looked specifically at young people. And this could be a concern. So if e-cigarettes are attracting significant numbers of young people to start smoking, then this would militate against the effects of e-cigarettes acting as a successful method of quitting for existing smokers. So something we do need to monitor and to keep our eye on. So if we're going to demonstrate this so-called kind of a gateway effect that e-cigarettes lead young people to smoke, first of all, we need to demonstrate that young people are using e-cigarettes on a regular basis. Then we have to demonstrate that use of the e-cigarette was actually responsible for the later smoking in people who wouldn't have smoked otherwise, because some of these people may have started smoking anyway. And this is quite a difficult thing to establish. We don't have a parallel universe where e-cigarettes don't exist, so we can make kind of comparisons across universes. Wish we did. So first of all, let's look at the evidence from surveys. So here we have 5 different surveys that have been conducted across the UK in people aged 11 to 16. involving over 60,000 young people. And the different colours of the graphs represent the different surveys here. So they're taken from different geographical areas across the UK and slightly different age groups here. So the first thing to point out is this column here. This is ever use of an e-cigarette amongst people who describe themselves as regular smokers. So quite high, quite a lot of experimentation going on there. If we look at regular smokers who use more often, on a weekly basis or more, somewhere between 7 and 38%. On the other hand, if we look at never smokers, so this is never smokers ever use, somewhere between kind of 4 and 14%, so that's just kind of experimentation. But critically, more regular use on a weekly basis or more in never smokers is extremely low. So across all these surveys, it's less than 1%, between 0.1 and 0.5%. So regular use of e-cigarettes does appear to be confined to those individuals who also report smoking. Those surveys only went up to age 16. The ASH survey was the only one to capture e-cigarette use amongst 17 to 18-year-olds. So here's the data on 17 to 18-year-olds. And again, if we look at never smokers, more regular use, weekly use or more, this is extremely low, peaking at 0.3% in 2015. However, although regular use might be low, some researchers have claimed that e-cigarette use can lead to tobacco smoking. 2 surveys from the UK and several from the US have found that young people who have never smoked but who have tried an e-cigarette at the beginning of the study, when they're followed up months or years later, are more likely to report that they have gone on to try smoking. And this has been used as evidence to suggest that e-cigarette use can lead to smoking. Well, there's certainly an association here, but the psychologists and scientists among us will know that an association does not prove causation. We can't tell from this kind of data that one thing causes another, even if one thing did happen before the next thing. That doesn't tell us anything about cause. Common liability is much more likely to explain these findings. So by that, I mean young people who engage in risky behaviours in one area are more likely to engage in risky behaviours in another area. That doesn't mean one causes another. That just means they have the propensity to try things. And in fact, there is some data to suggest that the opposite may be the case, that e-cigarette use actually is a route out of smoking for many young people. And data from the Smoking Toolkit survey, again, in young people aged 16 to 24 who reported that they have ever smoked, has actually been slowly declining since 2011. So until we see this kind of reversing, I don't think we need to be too concerned. E-cigarettes don't seem to be undermining this long-term trend of reduced smoking prevalence in young people. So I would say no compelling evidence there that e-cigarettes are attracting significant young numbers of young people who would not otherwise have smoked. Although some people can get quite alarmed about this, I just think, well, we keep calm and we just keep on monitoring, collecting data on this. Okay, so that brings me to the end. So just to summarise, I've gone through a number of myths, concerns, beliefs or misperceptions. You may have thought of many others, or you may have heard of people saying many other things. And this kind of misinformation and hearsay really can be a problem. We've got to come back to how harmful smoking is. Smoking is the worst possible thing that you can do for your health. It kills approximately 260 people in the UK. That is every single day. So these kind of misperceptions about vaping can lead people to just keep smoking. Smokers report that they like their smoking. They will always put off a quit attempt till tomorrow. And if they think that e-cigarettes are just maintaining their nicotine addiction, that they might explode, that there's negative perceptions around people behind them, the headlines are telling them that they're just as harmful as vaping, then this does more harm. It's just likely to keep people smoking. And smoking, as we know, is the real killer. Okay, I would like to acknowledge several of my colleagues, Anne and Debbie at the front here included, Sharon, for providing me with useful information, slides that I can use, data to present. So thank you very much to everyone that helped me with material for this lecture. And just on the last slide, these are the key information sources that I use. So mainly the Public Health England report, the Smoking Toolkit survey, and the Action on Smoking and Health survey. So over to questions. Thank you.